Dr. Morton, Amsterdam. I want to welcome you to the International College series of audiovisual history. I want to welcome you to Oklahoma City, where we're taping this, and you've had a little bit of change of climate, hot and sunny yesterday and cool and rainy today. But we do want to welcome you and thank you for your time that you've given us to give us a little insight and background of your famous life. You're an educator, you're a researcher, you're an author, a clinician, a practitioner. I don't know when you have time, and you're being retired and you still don't have time to do all the things that's necessary. But to begin, I'd like for you to give us a little history of your background as a youngster, as a young man, and what got you interested in dentistry, in which you've so greatly come to the top.
Well, I thank you, first of all, for the invitation to be here. It's quite an honor and pleasure to meet with you. It's the first time that we've met, although I've read about you for a long time and recognized when you were the president of the International College.
Thank you.
But going back to my childhood, I grew up in, I guess, what you would call a row house area in Philadelphia, which was a very erudite area, even though it was row house, and education was a prime concern of the area. And I had a brother who was 3 years older than me, who, from the time I could remember, always wanted to be a surgeon. Mm-hmm. And I never knew what I wanted to be, from a ball player to a fireman to a cowboy or what have you. But I had several uncles who were both physicians, several who were dentists, and I looked at their lifestyle, and I liked the lifestyle of one uncle who was a dentist who practiced on the upstairs of his house and did until he was 85 years of age.
Oh, that's great.
He was originally from Lynchburg, Virginia, one of 6 brothers, 2 of which became physicians and 2 dentists. One physician went back to Lynchburg. They all studied in Philadelphia, and one dentist went back to Lynchburg. But this uncle led a lifestyle that I thought was desirable, excellent. In fact, when I got married, I told my wife that's why I chose dentistry, was to lead this lifestyle, and she throws that up to me constantly ever since.
So you could be home.
So I could be home. And from there on in, my father died when I was 13, and we went on. My mother sort of raised us, and I went to an excellent high school, which has changed quite a bit since we graduated, and on to the University of Pennsylvania College. My big decision whether I could go to Penn or Temple, because the tuition at Penn was $400 plus $40 fees, and the tuition at Temple was only $180.
How about that?
And that was even before it became state-related. So that was a major decision at that time.
You bet, in those days.
In those days. When I think of tuition today, I just shudder. The tuition in our graduate program today, for example, is about $36,000 a year, and it's a 3-year program. And it's just a hard thing to realize. I fortunately was able to educate my 4 children. But anyhow, while at Penn, I decided I would take the 7-year combined course, and ended up similar to you, Bill, in that we both ended up in the accelerated program, ultimately into the ASTP. And first we held commissions, I believe, in the Second Lieutenant's Medical Administrative Corps. Right. And then they ended that, and we became buck privates, and then first-class privates, and then they ended that program at the beginning of our senior year, which by that time I had finished all my requirements in dental school, but they wouldn't graduate me, so I took a residency at what was then the Jewish Hospital, now Albert Einstein Hospital in Philadelphia. And my brother was surgical resident there, so I had many opportunities to assist.
Great.
And we did everything because they were short-handed, and brought in coronary patients, went out in an ambulance, assisted at major operations. My first operation was assisting at a Whipple procedure for carcinoma of the head of the pancreas. And 8 hours, I couldn't believe what I was seeing. And when I was do this, do that, and all of a sudden bring in the light, and I was talking to somebody else, and I reached up, touched the light, had to go out and re-scrub. But at any rate, I went back to school, and my senior year, I lived at the hospital, went back to assist as an instructor in both endodontics for Louis I. Grossman and in microbiology for then Dean and Professor and Chairman of Microbiology, Joe Appleton, which was quite an experience for me. And then, of course, into the service, and was stationed Marine Base. Well, I should say I got married.
Yes.
the week of graduation, I took my state boards, finished my state boards, got married, and was sworn into the Navy.
Right.
And then we went on a 1-week so-called honeymoon, and then off 5-day train trip to San Diego Marine Base. So in a sense, we were in the Army, Navy, and Marine Corps, one war. And there we were being trained for the invasion of Japan. And we did military, Marine base training in fatigues, subservient to the DIs, the drill instructors, in the morning from 8 till 2. Then they gave us an hour for lunch. And then from 3 to 10, we practiced dentistry. I got home, and we were the only married couple of our group that came from school, our friends, and I used to just flop into the house. And that continued almost 6 months after the war ended. When they dropped the bomb, we didn't know what it was, but we knew we weren't going to Japan.
Yeah.
And we were predicting 2 million casualties. But I had a great opportunity to work on that base. They let us do what we wanted to do. I was interested in endodontics, and I was able to do that, although it was not a big thing in California. I had to write home to get instruments to do endodontics, and in order to do it, they made me do apicoectomies because everybody was moving out. So anterior teeth were primarily what we used. And we were able to practice a high level of dentistry, and I became interested in the fact that it was both a recruitment center and a return center. The Marine divisions were coming back from the Pacific, and the recruits, they finally lowered the requirements from 14 articulating teeth, 7 upper, 7 lower, to 2 swinging jaws at the end of the war. You remember that. And I was aghast at the fact that there were so many young men who were edentulous, and that really changed my whole attitude in dentistry. I had to be a better thing than this, and the reason I guess I got interested in endodontics in dental school, it seemed to me even in dental school was the only field that was interested in saving teeth. Most of it was a prosthetically oriented education. First clinical problem we met was 2 edentulous casts upon which we set full denture teeth.
Right.
And I said then, it seemed like, or later, I said it seemed like we were burying our patients without ever learning to treat them. And that sort of started my trend of thought. And then I got interested in periodontics. Lester Burkett, our dean, had taken a 3-week course, and he came back and gave us at NYU under Samuel Charles Miller and gave us that course. And that also seemed to be a way of presenting and preserving teeth, and became interested really in what then was interception, and ultimately as our goal was to be prevention. And I don't know if we've really truly got there yet. We do have certain preventative measures such as fluoridation and so on. But I also was disturbed by the fact when I went to dental school, each clinical problem and discipline seemed to be an independent discipline, and nobody talked to each other. And then I watched the development of the age of specialization. Prior to that time, I guess we had 2 specialties, orthodontics and oral surgery. And periodontics was not recognized specialty. They were the only 2 recognized specialties. And as the specialties started coming into before and after recognition, they didn't seem to coordinate. And I said that this is like an intellectual Tower of Babel. We had to have a way of communicating interdisciplinary. And I only thought of treating the advanced case of disease, which formerly was thought not to be treatable. And they thought that periodontal disease, for example, was a disease of aging, similar to aging. In fact, Sherp once said that it was totally a disease of age, and all we thought, well, if we can control periodontal disease, maybe we can control aging. But I used that as a technique based on, I felt all clinical specialties should be based on periodontics. And that in order to practice prosthetics, restorative dentistry, or any phase of dentistry, even oral surgery correctly, you had to have an underlying background in periodontology, which really talked about the nature, development of the teeth, and the supporting structures of the teeth, and occlusion being the fundamental aspect and really the fundamental thing that brought everything together. And I've watched occlusion being everything, and I watch it being nothing, and it may be everything, it may be nothing in etiology, for example, but basically that's what we wanted to do, was develop and maintain a functioning occlusion, and I felt that this is best done by the natural dentition in health and the structure of the jaws. And so in developing this field, I did not want to develop a new specialty. I just felt this was a way of integrating all the various clinical specialties. However, as we started our training program, in 1955, we started our training program in periodontics, and our graduate program, by 57, we introduced periodontal prosthesis, but they had to all be accredited in periodontics first, and then they could go on Then it became a accredited program in periodontics, orthodontics. We even tried periodontics, endodontics. And that basic clinical science was introduced at the Graduate School of Medicine. But getting back again to my younger days, bringing it in, the life just never turned out the way I thought it would turn out. And dentistry became such a challenge. And it was, how to live it, breathe it, the discipline, the technical aspects of dentistry, and yet the biologic aspects were so important, and often they weren't integrated. I had a friend, a good friend, Peter Thomas.
Peter K.
I remember Peter K. Thomas. He used to say he couldn't stand a person who had a mile of tongue and an inch of technique. That was one of his favorite sayings.
Yeah, that's right.
And that was one of the problems. On the other hand, there were those people who were just technically oriented, and it was like working on a piece of wood or hardwood or so forth, rather than on a procedure. And then also one of the most difficult things, even in graduate education, is to take them beyond, trying to orient all of this and let them realize it's the patient that has or doesn't have the disease and what they're treating are patients. And I think that too many people have become totally interested in their techniques and procedures they're doing, and they forget that, you do the wrong thing on the right patient, the right thing on the wrong patient, you mix that any up. The idea is to do the right thing for the right reasons on the right patient at the right time. And I've learned that people change. As I followed cases now for 50 years, that I found that these people were not the same. I treated them when they were 20, and then they
Right.
suddenly are 70, and they're totally different people.
And
Their desires are different, their thought processes are different, their values are different. And the thing that bothered me to a great extent, and I didn't understand at first, is the average patient we treated was, I'd say 45 that time to 60. And these are people who became very successful. Basically, the average patient could afford the procedures that we had to offer, would do anything. Couldn't face the loss of teeth, and I ultimately classified them as dental neurotics. Neurotic in the sense they placed a higher value upon their dentition than the average in our society. At that time, I guess at one time, 50% of the aged society was edentulous. But these people went through a lot that we had to offer, and there was an offer. I just wondered, why would they do this, and why now? Why wouldn't they take care and get into interceptive procedures? And people became very successful businessmen. And suddenly they focused. I didn't know whether they suddenly acquired a mistress, or what factor caused them to change their attitude. But this became the thing. And then we were then really in the age of dental therapeutics. I said, I once wrote and said, we started dentistry in the 20th century in the age of ignorance.
Right.
And then we became a more learned profession. We then got into the definite age of therapeutics. And I remember Publish or Perish became post-war. We developed our specialties, and Publish or Perish became the sign, and I think many papers were written before PAC was removed in the field of periodontics. And it became necessary to really follow cases for a long time. And one of my fortunate things was I became interested in documentation. Strangely enough, first through oral medicine and learning, getting interested. And I once taught oral diagnosis and oral medicine, including oral lesions, at Temple, in which I introduced a course that I called stomatopathology, and taught that for some 20 years there, and later found out the students called it the mystery hour. But at any rate, documentation became critical, and I think it's still critical. And I said, if there's any good part to the litigious society we now live in, possibly even managed care, third-party payments, at any rate, it's going to demand better documentation. And I know in the litigious aspects, documentation is all you hear. So hopefully the radiographs we get will be readable, not poorly fixed, poorly angulated radiographs that come in a little brown envelope. And as you follow the case history of a disease, it's about all we can go by. It's because periodontal disease and dental caries are both different diseases but have many things in common. I found that they, and I could relate the two. As combined etiologic factors, I felt that they're both chronic diseases, both had acute manifestations. They were both very site-specific. And I said they had periods of exacerbations and remissions, or what might be called episodic in nature. And they were both destructive diseases, and they both created deformities. And that was a critical aspect, I thought, and understanding the nature that as the disease progressed, if you didn't intercept it early, both caries and periodontal disease, that the deformities created by the disease became much more difficult in therapy than the actual treatment of the active lesion. I think we understood this with scent and caries. We also understood prevention. We understood that caries, until pierce the amylodental junction was not significant and may arrest, and then with fluoridation it frequently will arrest. But once it pierces, it spreads right out.
Right.
And that treating a cavity or a lesion of caries, we could excavate the caries. And, but the real problem was restoration of form and function to the tooth. And then even more important than that, the tooth as it related to the entire system. That was a long time unrecognized in periodontal disease. We knew it was a disease that primarily attacked the interdental areas, created reverse architecture, and then what to do and how to treat this became a real dilemma. And that's when we entered the age of therapeutics. Osseous surgery was first introduced back in the 19th century by G.V. Black, by Ospia. They were taking away, they thought, necrotic tissue. Well, the body took care of that. So in the rebirth, I could always remember early arguments, and that's one thing I miss today, or the arguments of yesterday. Really were quite violent but interesting. And I remember Orban first opposing osseous surgery because he said the body would take care of necrotic tissue, but he didn't realize when Schluger started the rebirth, it was to create a corrected form and try to correct the deformities. The only problem there was that we went a little too far. In other words, it became a limited procedure, resective surgery, and correcting it, maybe 4 to 7 millimeters from the sphenoenamel junction. Beyond that, it did more harm than good. And then, of course, the goal was regenerative procedures. And that we tried, that came along with treatment of the infrabony type lesion, first described by Goldman, and then ultimately in 1980, Sterneman, Gottlow, and Linda came out with the membranes. They're really occlusive membranes. We did everything possible to try to prevent the downgrowth. And so the whole evolution of the field became very exciting. And then I watched us go from the age of Aquarius to the age of aesthetics. And that's both in plastic surgery and in everything is motivated by aesthetics. I can always remember getting a call from Charlie Pincus from California and Ron Goldstein from Atlanta asking me if I would become a charter member. They would like to start an organization called the Academy of Aesthetic Dentistry. And I said at that time, no, I wasn't interested because I thought it was time for me to resign from a lot of academies so I could limit my scope. I was spread out. And I also objected to the name. I said all dentistry should be aesthetic and part of the total dental facial aesthetic pattern. But I missed the boat there from the standpoint of we really went into the age of aesthetics, and that's a driving force today. And so we see really 3 driving forces. We see regenerative procedure. We see everything aesthetics, and I talked about the smile line and dental aesthetic, and then you have to differentiate between the patient's needs, which vary, and I recognize that way on back. Various societies had various requirements. Some primitive societies wanted to sharpen the canines, and some took a peg and knocked out a tooth. I remember when California particularly, when I was out there, gold was beautiful. Today, and I still think it's beautiful. And my best occlusion was a gold occlusion. And either acrylic or reverse porcelain pin facings, which was a difficult procedure and also difficult to maintain. And that became because of that nature, we worked out. But I remember when, 19 out of 20 cases were done with gold occlusions. And the biggest problem was cutting out the functional aspects, and when they smiled, they didn't see it. And then all of a sudden, they didn't want to see any gold, and I guess the ceramic metal restoration came in, and that became dominant in the reconstructive field. In our field, I guess most crown and bridge. And I don't think it'll ever equal, from a functional standpoint, the gold restoration.
Yeah, and it's very, as you well know, it's very, very important to that periodontal tissues and the sulcus and the whole gingival area. All those crowns that are in there create problems. Some of them.
Then, I never did a cast crown when I was a dental student. We used to do 2-piece sweat crowns. We had to sweat the metal, and they taught me how to fit bands, however, for impressions. Then we cast the occlusal, and we soldered the occlusal, and that was the crown we made.
You learned technique.
You learn technique. It's just like foils. We played foils till they're coming out of it. And the one thing we learned was digital skills and technique, and even though we abused them, used them where they shouldn't have been used and so forth, there are still indications for a good gold foil restoration, I think, when you look at permanence. But it can't show.
No.
And it was, but for the typical little class 3, for example, that was forever, and I got foils that I put in school that I still have the opportunity to see. Class 2 foils. And Then we had an inlay requirement, and I started out being a inlay. Most of my restorations were gold inlays or foils, and I became disenchanted with the inlay because I liked shoot cuss inlays. In other words, I didn't like the internal inlay as such, and I liked whether you could shoot the cuss. I felt I watched inlays where the margins were no better than the margin, really. And I also noticed, as doing endodontics, that a number of the acute separative pulpitis, which I think is probably the most painful experience a person can have. Pulpal abscess, and most of them were under inlays. And you lift up the inlay, and that little while of pus would on that face would just change. So I started to look at the inlay very seriously. Was it worth putting in inlays? And I became much more limited, except for the shoot onlay. I loved the shoot onlay and the pin restoration. And however, as I got into treating the advanced case, it also had its limitation. Next thing you know, I ended up with full coverage. And I remember my first full crown probably took me 3 hours. I had a heatless stone. We were operating in the service. At school, we operated at 3,500 RPM. In the service, we went with a rotary unit to 5,600. And we magnified it with large discs, 1-inch discs. I can remember experience in school on a 3/4 crown with a lightning disc. And I was doing it, a rotated canine. I did not line it, and I was going to slice, and the thing jammed, turned around, and cut the lip of my patient. I thought I was going to faint on the spot. I took the patient down to oral surgery, and they sutured it, brought the patient back, and the instructor said he would show me how to do it. I said, well, you know, a band. So I took a towel, and I was wanting to protect the lip. He said, I don't need that. Sure enough, he does it. Bingo. He cut again, and take the patient right down. Things like that, like have marked
that makes
impact.
the student feel good, too.
I said, well, why did it happen? I realized the rotation of tooth and so on.
Right.
But at any rate, we started with full coverage restoration. And then, of course, with the introduction of increased speeds, I remember we started out by increasing the size of the wheel on the delivery system of the rotary unit and taking the handpiece and diminishing the little spin, and that increases. We went up to about 15,000 RPM. Yeah. Some people with the belt drives went up to 50, but the vibration was not safe.
It was terrible.
And also at that time, we were really operating with up to 4 to 5 pounds of torque. Everybody remembers that, bearing down. Right. And then the Borden air rotor, I was a consultant at Bethesda, and I saw Dr. Borden working on his air rotor, and that made a big imprint on me. And at the same time, the turbojet came out, which had no torque with water, but it was not very efficient. I tried that. And so I decided I would work on the development of an air rotor with a proper water spray. One of the things that concerned me as a pulp biologist and endodontist was protection of the pulp under high-speed instrumentation. And it was interesting because of battles between high speed, even Bernier, who was then head of the Armed Institute Pathology. I remember being on a panel with him, and he was a prime advocate opposing high speed. We're going to burn pulp.
Lots of opposition, yeah.
And so I started to do research in the pulp with Harold Stanley and Carrie Longland, who was then at Buffalo. Later went to Connecticut, and we did a lot of pulp. We found out that we actually did less damage with high speed, light pressure, if you didn't abuse it, and we use less than a half ounce of pressure. You had to use high speed instrumentation like a paintbrush.
Sure.
And everybody wanted to build more and more torque, but it had to be sufficient torque, but torque was a dangerous thing. And then we found that it was difficult to learn how to operate at the high speed. When it went up with the Page Shays handpiece to 180,000 RPM, and then higher than that with the air rotors. And what I finally did is I took a postage scale, and I learned how much pressure I would put on this postage scale. I was operating in the lab just to get that down. And then I felt that if we introduced it, the classic people in the school felt they had to learn how to operate with low speed before they went to high speed, and I thought maybe perhaps if they never had that experience, they could start out with high speed. And I think probably that's what exists today. I don't know, because things change.
You worked with Star, didn't you?
I worked with Star Dental and developing with an engineer named Tony Turchi, who's unfortunately no longer with us.
When they were a family unit.
They were a family unit owned by the Liebs. Harvey Rosenbluth was a son-in-law, and Dick Delheim.
Yeah.
But the one I really worked with was Tony Turchi. And then as we developed the high-speed instrument, the diamonds we were using became critical, and I developed 3 types of diamond: the fine, which was a finishing diamond, the what we called the blue line, and then the green line, which was a rough cut, which we started out. And same size stone, but we went down and cut, and it just gradually. And all of a sudden you could do a full crown preparation in less than 5 minutes with full of water, but it had to be water. And then there were people, I remember the Loma Linda system, they thought they could operate dry because they couldn't see. And then vacuum became an important aspect, so we had to develop a vacuum. I remember the first manufactured one was Vacudent, and we had developed our own vacuum, and my first was a washing machine drainer. I used it as an aspirator. We reversed the thing, the clean washing, we had that. And then Mizzy started to manufacture those. They chrome plated it, and we bought them in a hardware store for about $11, and they sold it for $120. But that was really just the aspirator. Then we went to high volume vacuum, which pulled the water out.
Yeah.
And I can remember we first started operating with glasses and plastic aprons because you could splash us all over. But it worked out that you could see fine under a wet field. And as long as you did that with light speed, that the whole studies that we did showed that we did more damage at high speed. And then the instruments, of course, we were really, the peripheral cutting speed is 3 pi r, and we had this 1/2 inch heatless stone to do gross reduction, and we could reduce that to the size of the burr of the matrix screw, and we cut as fast, incidentally, at lower speeds with the large peripheral cutting, even with these large 1-inch discs. In fact, I look back at some of the cases I did in the 40s and wonder how I ever did it with those instruments, you know. As I got along, I had trouble getting the distal of a molar with some of these smaller instruments, but we used to go in with these stones, this, and you had to use many different instruments, cup cutters and so forth, and you could do it, reduce the number of instruments that you used, and really was the same instrument with different grits. And then the development of finishing lines, and then really working with a full coverage thing, the next important thing became, as we went up the route, lecture that I first started, I called the trip up or down the route as a progression of disease, how everything changed in the same patient. And as we worked on that, we had a different emergence profile. We were also learning how to put mascatory mucosa apical original mucogingival junction, and then we had a thick tissue where was formerly a thin tissue. And we developed the concept of evaluation with Cliff Oceanbeam, Arnie Weisskold, myself, and we started the memory of gingiva and the fact that you had different types of gingiva. You had the thin scallop, and you had the thick flat. And of course, as restorative dentists, we love that thick flat gingiva. The thin scallop was, if you ever wanted to show a good result, you always try to show a thick flat, a single crown. But you had to work with a different emergence profile, and this became a real problem. And then the argument was marginal placement. Should it be cervical, just at the gingival margin, completely away? Or if you can stay completely away and don't have any need to go near the tissue, that's the best place. But once you have to go, then I think you have to go subsulcular, in the presence of a healthy sulcus, and then develop an emergence profile. And I felt the worst place to determine the margin was just supragingival, and I said whether it was advertent or inadvertent. And that's still a big classic argument. But you had no effect upon it, and that was the greatest area of plaque control. And by advertent or inadvertent, some people wanted to be subcervical, but trauma during operative procedure, impression techniques, hyfurcation, obtundance, and retraction cord and so forth, and inadequate provisional restoration became a problem. And then, of course, we went to the advent of acrylics. And for the provisional, that was about 1950. And before that, all our provisionals had to be in gold, and we used aluminum shells and silver crowns and celluloid crowns until we got that patient take an impression, put in a gold provisional. And we started with the acrylic, but I could not maintain a good margin with the acrylics, and that bothered me. And finally, I was visiting a dentist in Connecticut, Louis Fox, and he was using hydrocolor impressions, and I watched him, and what he did is he took a block, he actually put on non-festoon copper bands over the thread as he put his thread around for retraction cord, and then he had the patient bite into acrylic, let it set, and then he put it down, and that gave him his packing before he took and opened up the sulcular areas and so forth. And then I wasn't happy with what it did to the tissues, but I saw that band and acrylic, and I said, if I properly fit and festoon those bands, same as when I take an impression, copper band impression, which again we were taught incorrectly. I call it the confined band impression technique, and that took me longer to fit a band than prepare a tooth. But if I did that, and then put the acrylic, and I carved it out, I had my marginal integrity. And that developed the metal band, the acrylic splint. And then ultimately I got an A company to make gold bands, and they were beautiful, but never popular because of cost, and yet the major cost was time. I always felt time was my major cost. and fitting the band properly and so forth. But when they first came out, they were 23 karat gold, just enough base metal to harden it. And they were sized like the Moico copper bands, and then we got a half size, as we were doing the lower anterior teeth, up to size 20, and rarely used any 20s, 18s, or 19s by the time we reduced them, but they were averaged out about 90 cents a band, as opposed to
really
a
expensive.
penny or so. Well, that wasn't it.
I
When
know.
gold went up, it went to $26 a band. So if they weren't popular then, and yet ultimately, and they weren't big sellers, and they stopped making them, which broke my heart. I still had enough of them, but one of our assistants, in fact, one of the office managers said, my God, look at all these 17, 18, 19, 20 size bands that done, and every time they ordered a complete order. And we were able to save the scrappings. As we cut a band and festooned it with the scrappings, went into a jar, and we mailed it back to May, and they gave us credit towards new bands. All of a sudden, they send all these unused bands back, and the dies in several had worn out, and then they decided, I think that triggered it. I always said that triggered it. They weren't going to make them anymore. So then we went back to gold-plated copper bands and to stainless steel bands. And but they were never like that. That gold band was... I once developed the philosophy that anything I truly liked, they stopped making. Anything.
Well, they stopped making, or they made it new and improved, and it never was the same again.
Never the same again. Everything new and improved. But no matter what I liked, they stopped. And that became a symbol. I used to say, I'm not going to tell anybody what I like. I'm not going to put my name on it.
Right.
But that whole development of the denometric system and the Starflight handpiece, then of course the Star kept on going, and then they ultimately sold the company. Syntex is who they sold it to. And then Syntex sold it now, I don't know what it's called, but the Perlman family, and they bought, first they had Virginia, they bought Shays company out of Virginia, Shays, Virginia, and then
Trying to think.
they bought Dentalese chair, and then they also have the Star. They bought the Star company.
I think it's Dentalese now.
Yeah, I don't know what they actually call it. That was a whole phase of my life, was instrument design and then equipment design, and then I worked with Ritter Company primarily, and I designed the modular unit and the flex arm concept, which they patented. I gave them the patent. I think it was supposed to be for $1, and they were generous. They gave me $100.
Hey.
But one big mistake I made was not forming a foundation. I never wanted to profit from anything. Even Star, the Diamond Stone became the biggest seller, but I got them to equip the schools. Ritter, when we redid the clinic at Penn in 1960, I guess 62, 63, they gave us the chair, the unit, and the light at their actual manufacturing cost. That was my honorarium. That was 131 units, I think.
That's wonderful.
And if you look at cost now, I think the chair, unit, and light at cost was about $1,500. And we raised the money through the alumni. And that was the first time through, I think it raised about $1.5 million.
Oh, great.
And then the chairs, well, what happened was when we got the reclining chairs and operated with a patient reclined, as you elevated the patient, the old bracket arm, if you weren't careful, just smashed the leg. And that happened a couple of times. So we got the flex arm concept. Now I think about every unit is built with that concept. And Ritter had the patent. And I don't know when it wore out or ran out, but almost every unit was built on that patent. And that was a major thing. And then, of course, we developed the Air Glide chair. And just at the time when I had buttons that my cabinets could come up, I always operated with 3 assistants, one to the right, one to the left, and one floating assistant. And we didn't tell everything how to be there.
Had to be there.
And my kids always complained at home when I asked for the salt, my hand went out for salt.
Right. Knew which hand to put it in.
Yeah, at any rate, I saw an ad on television where somebody was dancing around with a refrigerator. You pressed a button and had the AirPods, and the refrigerator moved all around. I said, why can't we do that with a dental unit? And Ritter did. And I don't know how long they made it, but we had the Air Glide chairs, and when I built the Myers Clinic, for our periodontal clinic Penn, I put all these Air Glide chairs. But however, we had a problem with it because I built that clinic in what was then the Evans Museum, which is an interesting story unto itself. Thomas Evans was a dentist, graduated from the original University of Pennsylvania, and went to Europe and became a dentist by preceptorship. He was supposedly a marvelous, marvelous dentist, but he became the dentist, all the royalty of Europe with the exception of the Habsburgs, but including the royal families of Britain. And he died. He left his will for building a dental school on his family estate in Philadelphia at 40th and Spruce Street, and the dental school should be second to none. And for a long time, we thought we really had that. We followed his edict. He was a remarkable man. He made money, I guess, in dentistry with his fees, but I understand the way he really made his money is they were building the Champs-Élysées, and he had all these prominent politicians and so his patients, and they would clue him in, and he bought real estate. And he was able to be a real estate mogul, and it was a really very fascinating story. And one of his most famous episodes, in fact, there's a book written on it, The Empress and Her Dentist, is during the Franco-Prussian War. He took the Empress Eugenie out of Europe to England, and he did it by dressing her up as a dental patient in his coach, and he had her all wrapped so she couldn't talk, and her handmaiden or whatever it was with him, and they took her out, and everybody knew Dr. Evans was a dentist or so forth, and anyhow, she got through, and he got her to England, saved her life, and she was very, very grateful for that. And we had this also was called a Museum and Dental Institute, University of Pennsylvania School of Dentistry, Museum and Dental and Institute. And that museum occupied a large area in the school. It was beautiful, all marble. And it had a great big vault, and all the treasures there. The coach was there, and all of these paintings that he acquired. And apparently he and Corot had I think it was Corot, had a mistress, kind of common or something, and not Van Gogh, I may have this straight. Someday you'll interview Walter Cohen. He has this story down pat. But my only interest in it was getting the space. And it was in the will, and Dean Burkett said you couldn't break the will, and I said, well, maybe get a reversal of the will. A reinterpretation now that that's part of the university and so forth. And it was in 1950 and our school was built. And sure enough, we went to Orphans Court, and they said, yes, we could use the space, provided all of the artwork and so forth remained on university property. So the paintings were put around the school. I had a beautiful one of his paintings in my office, down at the University Museum and all over the campus. But these two paintings, not Corot, wasn't Corot, Monet. Monet's Roses. And Walter Cohen went into the locker one day and found these two paintings and brought in some authorities, and it turned out, because there were some phonies, the Canaletto was a phony, and they were worth over each one about $2.2 million.
Oh, boy.
And finally, we got them out of there, and they took that space, but I never got it for the clinic I wanted, for the graduate clinic. They started to build the basic science building, which was primarily given by Leon Levy. It was another story. And they needed space for basic science, so they made it a multidisciplinary basic science laboratory. And well, when that was over and the building was built, then the vet school started to build, and they wanted to borrow that space. So it took about 5 years before I got it. And I was going to build a clinic upstairs, and it was not adequate, and I was told then they had nothing else to do with the space. If I could raise the money, we could have that space, and that's what happened. It became the Myers Clinic, Myers family, Sam and Charles Myers. They were Climax Dental, and they had been my dental suppliers, and they had originally given me a $50,000 grant, and which we used to buy assistants and what have you, and research, and then build upon that. And then when this came up, I said, well, we can take that money and use that as seed money. And then we'd raise it from the alumni, and then I had also just gotten the grant to train DMD, MD, clinical specialty, basic, and PhD. And we had 4 students in that, and I had an area in the back that we had built with 4 operatories. It was behind orthodontics and pedodontics. And in the middle of that, Cap Weinberger decided that they're going to end all these grants. And that was in the Nixon administration, and it was the first time that they didn't phase out grants. They just ended it. And unless they were in a terminal period of it, I guess one of the few dishonest things I ever did in my life was falsify some documents.
Go ahead.
And to get people through this grant. But meanwhile, they allowed us in this grant $75,000 for a new facility. So I sold them that facility for $75,000.
Good.
Brought them up from NIH, and used that $75,000 towards this clinic, which we called the Myers Clinic. And it was a 14-operatory clinic, but didn't house both classes. At that time, perio was 2 years, perioprosthesis was 3 years, and now, of course, perio is 3 years, perioprosthesis 4 years. But at any rate, so the classes had to be interchanged. One were in didactic seminars and so forth, and the other was in the clinic, and we varied it. When Jan Linde came in as dean, he thought that this was inefficient and that we should go to a center which was built by named for George Coleman, who was a prominent alumnus, and that had 29 operatories, and we had both classes. The only thing that happened is there was a cutback, a budgetary cutback, so they cut the staff.
That doesn't help.
So now we had 29 operatories, but we had a lesser staff, and that ultimately worked out, I guess, for a while, and then I don't know what's going on at present, but the Myers Clinic then became the oral diagnosis clinic, which is what I originally thought, because I originally thought hopefully we would have a graduate building, which never happened. And its location was such, and the setup was such, it could be used for oral diagnosis as they entered the school. But it was a wonderful place to train, and each one had their own operatory and totally walled off from the other. There was an open area. And that was the development of that. So it was a time that you had in dentistry as well. All the exciting things that changed. We went from low speed, high speed, and the development of materials became such, many bad. I remember Kadon, so-called plastic instead of fillings.
Kadon created a lot of endo.
Oh, boy, and how. I remember working on it when I was chairman of the Department of Endodontics with a microbiologist, Herb Koch, and we thought there was leakage. There was a microbial problem that if we entered with some kind of antimicrobial agent in, that would solve it. It wasn't. It was an expansion. Yeah. The coefficient of expansion was about 9 times out of 2 structure. And they just swelled. And then as they developed the composite resins, which reduced the expansion level of composites, and then, of course, I think they're still being abused. I think they're being used where not. And then I watched the amalgam war return. There was one in the 19th century, and then the return where it's supposed to cause mercury poisoning, whatever have you. All I know is it's the most commonly used and most frequently used restoration, and I don't think they've ever been able to prove any damaging aspects of it. I do think it has to be properly handled, properly condensed, and so forth, but it's a very serviceable restoration, even though I was a gold man.
Well, Maynard, we talked with Maynard Hine. Of course, he's quite a historian, and he read a little article out of a journal, and he put it in the Indiana Journal, and it was telling about amalgam and this, that, and the other, and the war and everything. It was dated 1849.
1849, that's right.
So
the big wheel goes round and
round and round.
It always reminds me, Maynard was a dear friend, a very
wonderful man.
And he used to send me a number of patients from Indiana. From Indiana.
Yeah, Indiana.
And at any rate, I can remember once being on a panel with Bernier and everybody. We were going to burn pulps with high speed in New York. It was one of the biggest meetings you ever saw. Everybody was involved in it. And they're really battles royal. And a little old man got up, I think Joseph Landa. And he said, he was from Europe originally, and his son, Landa, is now practicing in New York. He was tiny, his son is tremendous in height. At any rate, he got up and he said, it seems to me I've been through something like this before. He said, let me see. And Mike, where was this? And he said, oh, yes. He said, when they electrified the dental engine. They didn't do the same battle. The people with the foot pedal said that now the electrified engine is now going to kill the pulps.
That's great.
It'd be destructive. So, I say the big wheel goes round and round.
Well, Mort, I think this would be a good time if we just take a little break. And this has been very enlightening, and I've enjoyed, and there's been a lot of humor here and things that we've gone through, because you and I are contemporary, and I can recall and relate to things that you've done, and you've done them on a much more magnificent scale. But we'll take a little break, and in the second half we'll get more into a little perio and diagnosis and treatment, and get into the real me, the real you.
Yeah. Me.
Okay. Well, Mort, here we are getting started on the second half of our interview, and the first portion was highly informative and very entertaining for myself personally. We didn't spend too much time on periodontal disease, but we're going to talk about that a little bit more, and And I think that I feel very confident that you know a little something about this and will be able to relate some of the early things and what's happened over the last 25, 30 years and what you look for in the future. One thing that you're noted, you're called the father of the periodontal prosthesis. And I'd like for you to discuss that and explain that to our viewing audience and give them some background on it and your expertise. And I'll just turn it over to you and let you go for a while here.
As I said, I wanted a way of becoming an interdisciplinary, finding an interdisciplinary approach to clinical dentistry. And I felt that all the clinical disciplines, certainly as an undergraduate, an operative problem was an operative problem, an endo problem, an endo, and periodontics was not talked about too much when I went to school. And I felt that if we could get a subject, serve certain purposes, one was treating the advanced case of periodontal disease to start with, and then extend to all aspects of dental disease, particularly those of local origin, and working out the systemic manifestations and contributions to etiology, but looking first at local etiology, that if we could find this, that would have to incorporate all the clinical disciplines, periodontics, endodontics, orthodontics, restorative dentistry, prosthetic dentistry, and so forth. And now the same thing is said, the incorporation of implants into the partially edentulous situation. That's been part of it. And I called this periodontal prosthesis. And for a long time, I was criticized for being misinterpreted as being the replacement, or attempt to replace the periodontium by prosthetic means. The interesting thing is, with implants, that's exactly what we're doing. Right. But that was not my intent, nor was it my intent to start a new specialty. It was really a way of creating a new educational discipline. However, once our graduate students who take periodontal prosthesis got busy, at first I found the best general practitioner you can imagine. And in fact, the way we ran the program, we took the advanced case first, where they had full control of all the factors that were involved in the case, and they could manage that. And then at the end of the program, they were allowed to go back to general dentistry procedures. Take a case of posterior bite collapse that could be resolved more simple, since I always felt that number one, prevention, number one, intervention, then prevention, if we get it. And of course, prevention has played a marked role since my time in dentistry, the early loss of the 6-year molar with the sequelae, which I termed posterior bite collapse, mesial drift, mesial-lingual drift of the distal lower molars, and distal drift of the premolars and extrusion of opposing molar. And that, to a great amount, has been reduced with fluoridation in the fluoridated communities. You don't see the early loss. The first molar was usually lost due to caries. Wow. The upper molar is ultimately due to periodontal disease. And that's the whole story into itself, as you understand the whole biology of occlusion and the interception of disease. And I said that the average case of periodontal prosthesis usually had associated with 95% of them posterior bite collapse. If you had an intact dentition, you could manage that case in much more simpler fashion. And to me, the ultimate goal, beyond interception, as I said, and prevention of further breakdown, and good plaque control, that you could manage a case in the simplest treatment was the best treatment. In fact, I quoted Emerson when he said, "In simplicity there is greatness. Indeed, to be simple is to be great." And I took the liberty to add, provided in being simple, you not become a simpleton and overlook the problem.
That's a good quote. But
that's exactly the area. And what bothered me, of course, and mentioned in that Reader's Digest article, all the various treatment plans from, what was it, $500 to $25,000 by different people, is the perception. And yet I don't understand. It can be, I understand part of it, and based upon background, but I also said diagnosis was a critical aspect. And there can only be one correct diagnosis. Hopefully we can make it, and we have to have a way of approaching it, because we start out with a selective differential diagnosis, even though there are many different forms of treatment. Right. And if you can solve a case simply, to me, the simple treatment is the best treatment. And there's no question about that. If you can avoid it, and I would say most patients who referred to our office were referred thinking they needed periodontal prosthesis or extensive reconstruction, whatever you wanted to call it. And I would say that, better than 60 to 70% of them, we decided they could do without it, and at least they should be carefully observed and watched, and because it's a patient that has or doesn't have the disease, and I've seen the disease arrest itself. recognized early on, I guess, that both periodontal disease and dental caries were chronic diseases, as I said before, with periods of remissions, exacerbations, and they were site-specific. And if you could just control certain sites, you could perhaps manage the patient. And then watching the development of the field of periodontics, from local, I remember when I first went in the field, there were two approaches therapeutically. One was called conservative and the other surgical. The surgical was a gingivectomy, and then there was a fight between the embellished and the unembellished gingivectomy, people like Goldman and Glickman. And then you had the closed curettage like Isidore Hirschfeld, who was a master of it. In fact, I went to Isidore Hirschfeld to learn how they were playing. Also, there's a man, Chick Chaikin in Boston, who was excellent at definitive closed root planing curettage. And I think that's probably the most difficult technique of all of dentistry. Everything I've done, I think that to come to a definitive result, realizing probably that the only piece of calculus that's important is the last piece. Yeah. And then the open flap, I started out then with a unsophisticated flap approach. Open flap, I guess similar to a modified Widman procedure, and just for access and cleanup, and made certain observations, one of which was if I had what I then called a completely encased infrabony pocket, where the base of the pocket was apical or crest of bone as opposed to a superbony pocket, that if it was completely encased, that I got repair. And ultimately that was redesignated as, based upon the morphology by Goldman and Cohn and John Pritchard, as three-wall, based upon the number of osseous walls, with three-wall being what I called the completely encased. So it was anywhere from 3, 2, or 1 wall infrabony pocket, and our best results were in the deep, narrow, but now we call the 3-wall infrabony pocket. And then, of course, when we started that and we're showing repair, everybody talked about it being hysteresis or withdrawal, but they weren't. These were pockets. What was called the pocket, which I think is a terrible name, but I'll never be able to change it.
No.
Pocket to me represents a disease gingival attachment, because you can have a pocket without depth if you have a marginal inflammation of the clavicular epithelium, or you can have a 5-millimeter sulcus if the junctional epithelium is, the clavicular epithelium is intact, the base of which is at the junctional epithelium, one side by the tooth. And this became important in the regenerative procedure because the cellular origin of repair was critical. If you got a repair, this came out again strongly. Goldman brought it out in the late 40s, but again reinforced by the Gothenburg group of Gottlow, Neiman, and Linda, that if the cellular source was bone of repair in the pocket, you were going to get ankylosis resorption. If the source was connective tissue, you're going to get just resorptive. Similar to what you get, I guess, if you use an acid etch on the tooth. And if it was junctional epithelium, then you get a long junctional epithelium, if it was epithelial cells. And we try to inhibit the junctional epithelium by every means possible during those early periods. And then, however, when they came out in 1980, they said we weren't getting a new attachment. We're just getting either one of these phenomena. Well, I didn't see much in the way of resorption ankylosis. So either I had, over these long-range 25, 30-year cases or more, a long junctional epithelium, or I did get a true new attachment. And there's not too much human material around there because you get human biopsies, and you needed necropsy. I had one great case that I thought I would get for necropsy, and but I didn't. But anyhow, then it came into understanding the microbial effect. In fact, I think periodontal disease would be defined as periodontitis as a microbial infection, and I felt it could be modified by trauma from occlusion. We all learned early on that trauma from occlusion, counter to what was thought, could not cause a diseased gingival attachment or a periodontal pocket. However, it was shown that in the presence of an infrabony pocket, something by Linda and Erickson and Venstrom, showed that in the presence of an infrabony pocket and occlusal trauma, the rate and progression of that pocket was much more rapid and progressed greater. And that sort of put a better understanding on the entire thing. But the occlusal etiology, and that's been one of the problems with occlusion. At one time, occlusion was supposed to cause everything. I entered with an athological approach where I was told that it would cause everything, and all I had to do was put the case on the hinge axis and develop a bilaterally balanced occlusion. Everything was going to heal and go away, and it just didn't happen.
Didn't happen.
In fact, some of the writings said the calculus was going to fall off the teeth. The writings of Ernie Granger. But it was a great discipline, and it was a great way to understand the 3 dimensions of mandibular movement, and I still insisted that our graduate students learn how to pantograph and visualize this, but to understand how to avoid non-working contacts as much as if you wanted to put them in. So, and then, of course, selective grinding, which the pathologists never believed. They said you could not grind a case into occlusion, only out of occlusion, which limited their observations. But there are certain things that we did in selective grinding, and if I read the basic thing, that was right. You close vertical, and a lot of obstruction was done. However, if you went back to this retruded arc of closure, and you picked up a great mechanical advantage, certainly in the class 2 div 1 case or the neutral occlusion, and you ended up, if there's a reasonable slip between this first contact and the maximum intercuspation contact, you ended up with a diminution of the overbite and increase in the overjet, which without ever touching the anterior teeth. Yet if you read Schuyler, Miller said never grind the anterior teeth and so forth, but you disarticulate them, and in the periodontal case, the anterior teeth were flaring, and if it wasn't if you negate the tongue habit, they would come back as long as you supported. And then we developed a concept of what I call group function. It was different than most people's group function. I talked about the function of the posterior teeth as opposed to the anterior teeth. At the posterior teeth, supported facial height, or in dental terms, the occlusal vertical dimension. In addition, the trituration, milling of food, preparation of bolus of food, the swallowing. And the anterior teeth, in addition to aesthetics, phonetics, and incision, prehension, incision of food, served the purpose of discluding the posterior teeth, to protect the posterior teeth. And they had to work in a cohesive manner. And that I call group function. Most people talk group function as a cusp pass through on the working side, and with disclusion as they went away from bilateral balance. And that became our basic concept. And then with disclusion came ultimately the concept from the many of the pathologists, on the work of D'Amico, which I thought was a pseudo-anthropological study, but Charlie Stewart and Peter Thomas and so forth for discluding the posterior teeth by the canines, and call the canine protected occlusion. And that's fine if you have strong canines, number one, and the anterior group, number two, and also for the neutral occlusion. That it was difficult for, unless you had an orthognathic correction, either by orthodontics or orthognathic surgery, back to the neutral occlusion. It didn't work as well, and you had to take other modifications of the canine form. But basically, they were correct about discluding the posterior teeth throughout lateral excursive movements. And you're seeing that again in implants, and implant occlusion, peri-implantitis, incidentally. I wrote a position paper on it. I was asked to do that, and one of the things I said that I thought the peri-implantitis was basically a traumatic fracture after loading with the invasion of opportunistic microorganisms, infection. And also we noted that implants, just like posterior teeth, were the only teeth that individually and collectively could support facial height because of direction of the forces and the major oblique forces. 80% of the forces are designed to resist this, but at least you have a periodontal ligament. And with implants, you don't, and they're primarily designed to resist vertical force, vertical loading, and ill-designed to resist lateral forces. So the ideal implant situation would be have natural teeth for disclusion and implants that maintain facial height. But and you went through the whole story to connect, disconnect. It's become a very interesting field to observe. And one thing I'd like to be is an observer. And angels tread where fools may jump and leap. So you got to take, and good documentation is your critical thing. And that's been my primary concern now, and my primary interest is long-range, following cases over a long-range period, and why they were successful, why they were failing, and so forth. And I have a whole series of cases now of over 40 years. And it was an interesting experience, how they were maintained. The maintenance is the name of the game. Saul Schluter once said in treatment of the advanced case, survival was the name of the game. And that's changed. But meanwhile, understanding better the nature of the disease, the deforming nature, then we started the area of dental therapeutics and periodontics, and we introduced mucogingival surgery, osseous surgery, regenerative procedures, both using membranes. First started with a millipore membrane, then the Gore-Tex, non-resorbable, and trying to get resorbable, now using many instances resorbable membranes. And it's still interesting, on the infrabony pocket, the pocket that responds best to the regenerative, so-called regenerative procedure using membranes is still the three-wall infrabony. Two walls, and we have the same results we had before. The only theory, or theoretically, we have a new attachment, which means new attachment, new fibers inserted into a previously infected, chronically infected root surface, and then new bone. At first, when they looked at this, Neiman and so forth just wanted to see fibers inserted into previously chronically infected, but I can't follow that as a clinician. I got to see bone and long range. And then we got into aspects of tooth movement as it affected it. As we got into mucogingival, osseous surgery, became apparent to me that resective techniques were, first of all, very limited, maybe 4 to 7 millimeters at outset from the CEJ with a normal morphologic form to the tooth. Short root forms became less. Long root forms maybe a little more, and then the relationship of where was the bifurcation or trifurcation was critical. So that, and incidentally, as we got into this form and types of gingiva, embryologically I started studying the form and the eruption of teeth, and the observation of the fact that the alveolus was a product of the tooth, erupted with the tooth, and accompanied with the tooth and changed in position, was one of the things that caused some of the deformities with loss of teeth, extrusion of teeth, and posterior bite collapse. And also the fact that the form of the crown of the tooth dictated the osseous form, and the tissues that covered it to protect it were based upon the underlying osseous form. But the whole cervical anatomy of the tooth described cervical anatomy at the CEJ level, allowing for the biologic width. And then all this changed with disease attachment and apical shift to the junctional epithelium and loss of attachment. So these became interesting phenomena, along with what I just mentioned, the ICRC discrepancy. And then I got, early on, I had a deep bite case. Where the lower anterior teeth were really biting in. I didn't know what to do with it. So I went to an orthodontic friend. He said, well, you put in this Hawley bite plane, and it'll depress the lower anterior teeth. And I put the bite plane in, and I waited for him to depress the lower anterior teeth, and that didn't happen. But I noted that the posterior teeth, the patient really wore this. Most of the time, the posterior teeth erupted. And that became interesting. And I also, as a prosthodontist and restorative dentist, I had two problems. One, if a tooth erupted unopposed and it had inflammation, I didn't know, sometimes it looked like the tooth was growing out of a socket, and sometimes the socket came with it, and I realized that the difference was inflammation. If the tooth erupted with gingival inflammation, as it erupted, you were getting gingivitis with attachment loss, and the tooth came down. If the marginal gingiva was healthy, the alveolus came with it. Well, this made me understand some of the problems with the maxillary first and second molar by the predicated site. One of the reasons that's a site-specific area that we understand. And also the fact that as the tooth tilted, lower tooth tilted, and Orban and Ritchie made the observations, I guess which you all should have made, studying Wheeler's anatomy, that the crestal anatomy followed the relative heights of the adjacent cemento-enamel junctions, gave us a better understanding into the types of lesions that we might develop. We knew that periodontal disease basically attacked the interdental areas, and that created reverse architecture. Then we got into angular defects, and we had to determine was an angular defect more than just an angular defect. And I'd have to say no. However, angular defects lent themselves to infrabony pocket formation. And this was one of the reasons why so many people indicted occlusion as for causing the infrabony pocket, because a common site for it was that collapsed lower molar into the edentulous area where there's sufficient bone to get an infrabony pocket, and you had a relative disparity in the relative heights of the cemento-enamel junction. And for that reason, with the opposing distal involvement, not understanding was thought, in fact, the paper by Glickman which said pathways of inflammation may be altered by a direction of force applied. But they were so many different factors, and there's never been any real evidence that this was so. So that dilemma constantly remained. But then with periodontal disease, we had regenerative procedures, we had mucogingival procedures, we had free gingival grafts, we had apically positioned flap. This all started with a very brutal procedure, which we called the pushback or denudation procedure. And I guess that was Ocean Beam, Schluger, Pritchard, and that whole group, and we all tried it, and it was not a very pleasant procedure. And I remember audience asking Dennis Walter Cohn once, we were giving a course together, they said, do you have any pain with that procedure? And he said, no. And I said, you asked the wrong question. You asked him if the patient had any pain.
True.
But at any rate, it became much more sophisticated, kinder, and the factors, many of the problems were associated, became very, very critical part of periodontal surgery, so that most periodontists became much more sophisticated and actually became plastic surgeons. And if you really understood the nature, the restorative dentist was the same. So putting it all together, you had the mucogingival surgery, both including osseous surgery, regenerative procedures, and the restorative dentistry were necessary to restore form and function. And what we looked at as a functional occlusion was a stable occlusion. We didn't get into any various concepts, and one that could perform all the factors required of it in mastication, was stable, was self-cleansing, and also amenable to ancillary means of home care. And one thing reverse architecture did was make it unamenable to home care. And restorative dentistry, frequently, without proper tooth preparation and following proper periodontal preparation. That became a critical problem. Preparing a tooth did not begin necessarily with cutting the tooth. You may have to position the tooth correctly orthodontically. If it was malpositioned, you had malrelated, and although it had to relate to the problem. And also prepare the tissues to healthy tissue, healthy sulcus, then you could think in terms of tooth preparation. And particularly as you got into the diseased mouth, if you're dealing in a healthy mouth and you're just restoring caries in a resistant patient, fine. I guess you can just go ahead with blanket restorative dentistry, and just so that's good, clean, and it doesn't become an etiologic factor. And one of the great things, of course, is if you entertain a case, full dentition, no restorations present, and they don't have juvenile periodontitis, because you see that in acute localized precocious juvenile periodontitis, which was a outgrowth of the old idiopathic periodontosis, where bone loss preceded pocket formation. Well, rare is the mouth that didn't have plaque. And plaque became the plague. And also, so then as plaque became the plague and we started to understand, went from the specific, from non-specific plaque theory to the specific plaque theory, we know a number of organisms are very consistent with periodontal disease. And then we had this one organism that was defined with juvenile periodontitis, which is Actinobacillus actinomycetes comitans, particularly Y4 variety, which even to this day it became interesting because it was so commonly associated. And this was a disease where involving a young individual, involving the 6-year molars, and usually a mesial aspect of the 6-year molar, and or the anterior, centrals and laterals, maxillary and mandibular, and or some combination thereof, in which first organism, when the rebirth of it, after idiopathic periodontosis was actually voted out of existence by a meeting of the oral pathologists and Academy of Perio. And that was, I said, because you didn't see it. It was first described by Gottlieb, but Paul Baer, I think, was probably responsible for the rebirth as an infection. And the tissues were non-inflamed. All of a sudden, your probe would fall in, or radiographic examination revealed these lesions. And it was interesting as to why, even in the idiopathic periodontosis case, why were these teeth the ones involved? And they were the first in the mouth and the permanent dentition. They were also present during the mixed dentition, and infection could be present. And as opposed to chronic adult periodontitis, where the distal of the upper molar is involved, the mesial is involved, and the mesial of the lower molar, not the distal. So that became a very, very important case, except that the occurrence of it was not very good. In fact, we're seeing fewer of them today. And, but it was an interesting thing because we had a common association with this organism. And then they noticed there was also a compromised neutrophil incompetency that occurred with it. And also they looked at the familial aspects of it, the genetic characteristics of the case. So it was easy to get grants to study precocious localized juvenile periodontitis. And now they defined it into early onset periodontitis, refractory periodontitis, which is hard to define, and chronic adult periodontitis, and then those factors that have systemic manifestations. So it's a complex, and so when we talk about periodontal disease, it's really periodontal diseases. Diseases, right. And I think our understanding of it is becoming more and more, although I guess, you know, like the definition of a professor, they say the more he learns more and more about less and less until he knows everything about nothing. Yeah. Yes. I remember having a graduate student, Bob Jenko, who was brilliant, and he was our first DT1, Dental Training Grant 1, in microbiology, and we decided we were also going to combine. That was the first combined program, which was the birth of a whole series, but in periodontics, rather, clinical periodontics. However, he was one of the few. There were some who were both outstanding, both the basic science field and the clinical field. Frequently, it was one or the other. But when he finished his program, I said, Bob, I said, Mike, there's going to be a lot of microbiology. I was like, the real answer is immunology. And so he went off and he continued his training in immunology. And it seemed with immunology, and that's where the answer is, again, it's the host resistance factor, what makes one person more susceptible to disease than another, and a whole cause and effect process. But it seems the more we learn, I don't know, the more complicated it gets. But they're learning a lot, and ultimately, hopefully, we'll be able to make determinations and be able to predict the episodes before they occur, if we could abort them, and also why certain sites, other than some of the anatomic aspects, like the distance between the maxillary first and second molar and so forth, we understand certain aspects of that and why it predicates to being a citing factor for disease. In fact, if you had to do an epidemiologic study for the mere presence or absence of periodontal disease and given 30 seconds to examine a patient in a large sample somewhere, you take your probe, you put it right distal to the first molar. And because if they have it, that's where it's going to be.
That's where it's going to be.
That's where it's going to be. And that's the most common point of distal root resection and so forth. We understand the sites there. And then, of course, with regenerative procedures, one of the factors that are making real progress is furcations, filling of furcations. In fact, and then using regenerative procedures, we got into, and I wrote to that perhaps with augmentation procedures, lost tissues perhaps is just as important as the treatment of infrabony lesions and so forth. And as far as the gaining of attachment, it's the infrabony lesion that we can fill to the height. One thing we haven't learned how to do is creep up, and not with bone, anyhow, attachment. Although, one of the observations we made, and incidentally, everything I ever observed was serendipitous. I used to sit and study. I had 2 projectors, never thought I'd ever be showing slides to anybody, but I would sit and project before and the changes, and why did this occur? And reading the Bible, actually I was hearing a sermon once, and the minister said that experience is the ability to recognize a mistake when you do it again. That stuck with me. I said, gee whiz, and that's true.
It's good, yes.
And it's good. And
yes.
We're still probably making a lot of mistakes, at least I know that I was, and because some things I did multitude of times until suddenly I recognized what was happening. And then we made these observations that were serendipitous as far as I'm concerned, and then to see if we could duplicate them on a repetitive basis, which became much more difficult in the human than an animal study. And particularly when it came to occlusion, the other thing we recognized, which was when I finally got straightened out from a totally confused individual, I said I joined a fraternity called GAMIC, GMI confused. Every case was different, an occlusion and different occlusal concepts. And I heard an anatomist, Harry Zischer. I gave a lecture, and I went out to see him in Chicago, and I told him my problem. And I started to work with him, and he said, if you want to understand the occlusion of the human, you have to understand all related animal forms and the differences. And he said, finally, the fact that the masticatory system of the human was one of the prime differentiating characteristics of the human from all other, even primates. Its envelope of motion was shown by Posselt, was totally different, rhomboidal in shape, and all functional movements were combinations of sliding hinge movements. They didn't make pure movements except close to human, under certain orthodontic, a deep bite, a reverse deep bite. And I can always remember, again, going back to school where we made full dentures, and we had to give our patients chewing exercise. They had to learn to distribute the food on both sides to chew. And it invariably ended up on one side, and I'd go back and teach them. And I'd sit there for hours. This professor made us. Then I realized that the human really was a unilateral masticator. He chewed on either the right side, the left side, but except under special circumstances, never on both sides at the same time. And that also he had a very unusual wide range of mandibular motion. And therefore, all the trauma experiments done on beagle dogs, squirrel monkeys, gave us very limited information, okay? We could apply a device and we could get a replicated lesion. Doesn't happen to human. I've seen a patient who I always said worried me was minimal plaque, maximum response. Slight prematurity and the tooth is wobbling. I've seen total malocclusions. I've seen cases where only one tooth remained with a swinging partial denture, 4 millimeters of bone, and boy, you'll take half the jaw and you take that tooth out. And I'm sure we've all seen that. So these were things that really bothered me, puzzled me, and I would say that my major preceptor was Harry Zischer. I said, Lou Grossman got me into understanding you could save teeth with endodontics. He was a father of modern endodontics. Appleton in microbiology, and then Henry Goldman with his infrabony pocket, and there's also concept of form. And then probably the most exciting thing that happened to me was working with Walter Cohn. And we had a collaboration that was second to none, and I was had to be a moderator at a meeting, taking over. In fact, it was Harry Zischer who was supposed to come in, and we had a tremendous snowstorm. It was the Philadelphia Society of Periodontology, 1951. And they asked me to moderate, and I was pretty young once.
Yeah.
We're contemporaries, so you don't understand my feeling.
Understood.
And I'm for all these people, and I'm moderating, and I got again into what I thought I'd learned from Zischer up to that point, which was about only a year exposure. And then I had a young man in the audience that asked some beautiful questions. So after that, I went up to him, I said, "Who are you?" And he told me his name was Walter Cohn, and that he was just a resident at Beth Israel Hospital, Boston, with Henry Goldman. And he was just in for a short period of time. His father, incidentally, was the first limited practice periodontics in Philadelphia, and also then headed the school district. And I was very interested. I said, "When you come back to Philadelphia, get in touch with me." Well, we were at a fraternity convention, and we met. To our wife's chagrin, we disappeared throughout the whole convention, just discussing many things. And then we started a collaboration. Every Sunday morning we met to discuss the literature, differences in concept, philosophy, and so forth. His background, he was 5 years behind me. I didn't know him as an undergraduate student. Most of my undergraduate teaching, while he was a student, was at Temple, and he was at Penn. And then we met every Sunday morning and for these discussions at my house. And we'd look at cases and so forth. We'd argue it all out. And then he would spend every Saturday afternoon in my office and watch me work. He never did restorative dentistry after school, just a periodontist, but he got a great understanding of restorative problems, and I think he understands as much as anyone. And then we started to give a course together. And ultimately, we started the graduate program. It was done in combination with Beth Israel Hospital, Boston, with Henry Goldman, Lester Burkett got together, and we were the mainstays down at Penn. The first year was spent at Penn. The second year they went up to Boston really for their clinical year. And by 1963, from 55, I said, I can't do this anymore. Just at the time we were able to communicate, they go off. So at Beth Israel became Boston University, and we decided we would split the programs. And so we split the program from there on, and we each ran our own program. And still collaboration, we went up there, and Goldman would come down, but basically the students were different, and then it became a very exciting thing. In 1957, we also introduced the periodontal prosthesis. And I had two students that were preceptored. One was Leonard Abrams, who's made a marked contribution, the Abrams-Krauss textbook on anatomy, and Charles Yergi, who ultimately became the dean of Connecticut. He really built that school. But he was the only dentist ever to be awarded the Pennsylvania Plan for Training Scholars and Researchers. All the rest were medical students or so forth. But he wouldn't take it unless he could get a clinical background, so I agreed to preceptor him in the office. So those two were preceptored. And the other one that was preceptor was Harry Bohannon, who became the dean at, ultimately at Kentucky. And then we gave our first course in '59 for Saul Schluger, who moved out to Seattle, had the program, and that was a funny experience, but it became a very lasting and gratifying experience. And for our first graduate student, had been with Jerry Stibbs, the famous gold foil operator. And Dave Boudreau taught with and worked with Stibbs, practiced with Stibbs, and he, after he took this course, decided he was going to come into the program. He became our first formal graduating student. He later became the dean of Georgetown, associate dean of Georgia. And the other one was Ralph Eudalis. I don't know if you know Ralph Eudalis.
No, I know.
Fantastic. He also took the course, went back, sold his practice, was from Edmonton, Canada, came back, took his graduate training, and then he took both perio and prosthodontics separately. Ours was a combined program. And he started their graduate program, and he's also a fantastic operator. But that growth of that program, and we were the only ones that consistently demanded that periodontics be certified in periodontics before they went to restorative dentistry. And then once there was a meeting in the American Academy of Periodontology, I was on council at the time, where they outlawed any restorative dentistry. To be an active member of the academy, to be an associate member, a general practitioner or something, but they outlawed periodontal prosthesis, and I resigned from council on that basis and didn't go back to an academy meeting for 15 years or so, and then I wouldn't be in the program. And then about 2 years ago, as times change, I was awarded honorary membership.
There you go.
And what happened is, I think the advent of implants is what changed their attitude. Now they have total meetings and workshops on how to integrate because they're implants, just like it was restorative driven. Treatment in the advanced case was restorative driven. You ended up with a case, you had to set up the case, and now with implants, they got involved with emergence profile, which I started to say before, we got to get involved with as marginal fitted restorations. And now with the abutment implant abutment restorations, that became a very critical part, and how to develop implant sites and so forth, and the person that has to develop it. And when it came to this country, and in Sweden it was really full dentures with a high waterline, and that wasn't acceptable in this country with the age of aesthetics that came in, so we had to find ways of handling it. And then also the advent of the implant assisted restoration, in other words, integrating it with the natural teeth that were left. And that presented a whole multitude of other problems. So the whole thing became so involved that I think the members of the Academy have now recognized this, and I think now with all the workshops, there'll be a whole different approach. And when we first got cases, when people started to do implants, and Brandemark, I guess it started in this country about '82, when Brandemark first came over, periodontists were not allowed to take the Brandemark course. They had to go to Canada. Some of my formers went to Belgium to take it and so forth. And when Jan Linde became the dean, I brought him to school as dean. We met with Brandemark and told him that if anybody should do it, while you're involved with a mixed with partially edentulous situations, they're periodontists who are used to dealing with this. And he finally agreed, and it opened up. And then you now have so many implant manufacturers that has to weed out that now anybody can do it, and everybody and their uncle is doing it, which is fearful. I think an implant bridge is being done by people who couldn't make a decent fixed restoration, fixed bridge. And
Well, we'll have to wait and see how long they last.
that's the other thing. And then the thing is that they put it into our graduate, the periodontal requirements of our graduate program, and I had to build a clinic, and then ultimately Brandemark, Noble Pharma built us an implant center at Penn, which was really just 2 operatories. I took one of our spaces and built a 1 operatory setup. But what happened with the students so anxious to do implants that I sit in treatment plans as they come up, and it seemed to me that the only time they were going to, well, they started out, the patient wouldn't accept implants. Even with augmentation procedures as they develop, and even before that, couldn't have implants. Then they tried to save the teeth. I said, my God, you're periodontists,
Yeah.
And the natural teeth are still the best.
Let's go the other way.
And we have evidence that these cases, in fact, I have an interesting topic now for the Quintessence International Perio-Restorative meeting in Boston next. I want to get back from Israel. And my topic is non-implant decision-making. And I'll have to go back and look at these cases. How would you treat them? And most of them would be. At one time, they were going to be dentures, full dentures. Now these same people are going to take out these teeth, and I have them now for 40 years, and the teeth are still there. Also go downhill. But it's very useful. We can modify our treatment. We used to keep teeth to the bitter end. Now, should you take out teeth sooner rather than later, because the implant site, you have enough bone. So many of these problems now have to be worked out, but I agree with you. You and I went through the golden age of dentistry.
Oh,
We talked
beautiful,
about
yes,
that.
beautiful.
I mean, our careers are almost parallel one another, but from our educational experience, the combined course, the service, our experience in the service, and then going into general practice and teaching and building. So we had the same kind of background, but it's a whole different
It's a different world.
today.
Yeah.
And I think we were very fortunate in being in that world, even though with all the innovations that are coming in, but the cost of education that's going up. Our graduate program is exorbitant. It's almost $36,000 a year, and it's a 3-year program rather than a 2-year program. Periodontal prosthesis is 4 years, and fortunately there's no tuition. Actually, we work in a teaching component so that they get a waiver of tuition and a slight stipend. And that's one of the problems with dentistry as opposed to medicine. Graduate training, except for the general practice residency program, where they get a stipend, is supported by the students. There's tuition. Whereas in medicine, all the residency programs are, they get a stipend. So that the costs of a dental resident is specialization. And I attended the reunion of a 25-year class from Penn, and they made bragging that 80% of that class, they graduated in 1960, that went into dental specialties. And I think you're going to start seeing a reversal now. The general practitioner is going to be part of it, and I think managed care is going to force that. And hopefully, though, we get a highly educated general practitioner. And to me, I always classified myself as a general practitioner. I did everything. Once I was able to farm out orthodontics, I did. Even endodontics, I did, and even periodontics, preparation of the patient, and so forth. I had enough to do with just my own procedures and my limited time being half practice and half teaching. and really behaving like it was full-time in both.
Well, I don't see how you've accomplished in 24 hours a day what you've done, and here you are retired now, and I think you're busier now than you were when you were practicing and teaching, it seems like.
Not really. I may be traveling a little
well,
more.
That's what I mean, though.
Because I don't have the obligation of being back. I never wanted to deny my students. And what I'm doing now is consultations, and I'm going in and still going into the office to follow long-range cases I followed for all these years, and I think that documentation is critical. And as I said, one of my fortunate aspects was I started documenting early.
Yes.
And I documented basically so I could study cases, not the...
Well, this is history.
That's history.
Records
That's
are history.
exactly, records are
And
history.
young people don't accept this very much sometimes.
That's right, and I said based upon that documentation were serendipitous observations, and clinical observations were critical, and being a clinical scholar is a very, very difficult, particularly in clinical practice. It's costly. Taking photographs is costly.
Right.
Making sure the x-rays are perfect. The unfortunate thing, if you have to teach an emergency and the preoperative films or preoperative photographs come back, or don't come back.
Or don't, yeah.
And that's always a great case. So it's tough.
Yeah.
And it's one thing that worries me, and we try to teach our students to do, is to document. And we know they document their board cases. But beyond that, it becomes a very costly endeavor.
Yes.
And I hope they do it, because they'll not learn unless they do it. They evaluate what they've done, the effectiveness of what they've done. And it's really a lot different. And also clinical observation, and the clinical scholar really is who provides the problems that have to be solved by basic researchers. And I think now what we're going to next era I think we're going to enter is effective molecular biology. And I think that'll have a great deal to do with therapy, BMP for regenerative procedures, putting bone morphologic protein in, and all the variations of that go in, and with the augmentation materials that we use, from decalcified freeze-dried bone. I always preferred osseous coagulum. And of course, iliac crest was used early on for infrabony pockets, and then we found out if we used it active, it was so hematopoietic that it caused resorption of the root, so they had to use a frozen iliac crest. And it's funny, now they're using it for sinus lifts and so forth. That a patient recently had one. He called me on the phone. He said, yeah, they did a sinus lift using iliac crest. He said, and I didn't feel a thing. He said, but I'm walking with a cane. 3 months he's walking with a cane. So that's one of the problems. What sources are using now for sinus lifts, which I worried about, are chin grafts, which is an excellent source, properly used, and also the occiput. But I always felt that the iliac crest, I wanted a surgeon. I didn't want to do that. Chin grafts, I think, can be handled by the maxillofacial or periodontal surgeon. The occiput, I want a maxillofacial surgeon. That was first used by, I saw its use, was by Harvey Rosen, who was chief of maxillofacial and plastic surgery. Also went through Penn, the combined medical dental program. And for orthodontics, use of screws and staples. But even that, you watch that Age of Aesthetics, and it's become easier to do plastic surgery than orthodontic surgery. But that whole field, we didn't have that really. You had the Obergieser, for a prognathic case and so forth, but many of the cases that we had to compensate for a non-orthodontic correction or an attempted orthodontic, which you couldn't really correct because it was beyond the scope of just classical orthodontics, now are being treated by orthodontic surgery if the patient will submit. And it's just a very, very interesting development, the scope of where dentistry is going today. And yet the thing that really truly worries me is the attitude. I think it starts with the student. There's a different attitude of the students today than when I watched them come on up, for the most part. I said the best students that I ever had were those just post-war VA, came under the VA program, and who came back in the latter part of the 40s, 48, 49, 50, who came back and completed their dental education after the war. They were very mature, married with responsibilities, and boy, they were a serious student. And hopefully, you run into serious students today, I'm not denying that, but again, when you look at the attitudes, the vacation time, it seems to me the more tuition they charge, the more the universities give them shorten the curriculum or something, I don't know. Having put 4 children through school and then grandchildren, entering. It's just a whole interesting change.
Well, it's a little different than when you and I were. I mean, it's talking like a couple of old guys, but
We are.
It was different because we just gotten out of the Depression, and then we were right into the war, and then the accelerated programs. And these young students now, if they don't get a month off, they're under stress, and it's pretty difficult.
That's with all the financial difficulties you worry about them. They still go off to the islands.
Yeah.
They got to go off to do this and do that.
That's right.
That's right. Our backgrounds are so similar, and they had to create an attitude and a focus and a sincerity. I mean, what we went through during the 30s, Depression, and then going through school with a war going on, not knowing whether you're going to go through school or whether you're going in. I went going down. I wanted to join the Air Corps, and they kept sending me back to school. They didn't want us. They said they're going to need physicians, dentists, and so forth.
Right.
And that's why they took over. And then the observations that I was able to make, I just couldn't believe when I got into the service. I said we treated people coming back from the islands, the Marines coming back, 1st, 2nd, 3rd, 4th Division Marines coming back, and then we had these young kids with edentulous, 17-year-old, and so many of them when they lowered the dental requirements, and that really made a marked impression upon me. And I thought something was wrong. Most of them just visited dentists to have a tooth, what they call drawn, from off a farm or something like that. And I thought it was a very sad experience. But then also another thing interesting was the observation of so-called trench mouth.
Yes.
And acute necrotizing ulcerative gingival stomatitis. When I went to school, we saw a lot of it. When I first went into service, we saw a lot of it. When I came out of school, we saw a lot of it. And when's the last time you saw one?
I've almost forgotten the term. I hadn't thought about it in so long.
Right. And I remember when they used to, when I went to school, if a kid had trench mouth, he had to boil his utensils and everything else. And it went back, and then Schluger, during World War II, made the observation that basically it had an emotional component. Local environmental factors that lend itself to it, and there are organisms involved in it, but it was an emotional disease. And I don't know whatever happened to the disease. I'm sure the stresses there that we talk about, and whether the flagrant use of antibiotics did away with
Maybe Listerine cured it. I don't know.
Listerine cured it, yeah.
That's cured.
Vince, remember Vince?
Oh, yeah.
That was
It's cured all the-
superoxide or something.
cured all the
That's how I got his
periodontal-
name from. It was called Vincent's infection.
Yeah.
But it's interesting that happened. And that same thing is happening in a sense with, in our area at least, with acute precocious localized juvenile periodontitis. For a while we were seeing a lot of these cases, and we started studies on them, and then all of a sudden we tried twin studies, we tried familial studies, sibling studies, and then you just don't see that much anymore.